Hi, my name is Sophia Jiang, and this is Diseases and Epidemiology for One Word Anchor. Today, we're going to be doing Lesson 5, the epidemiologic approach. So let's get started. And as a reminder, all information is from the CDC. So the epidemiologic approach. So the way we approach epidemiology is very systematic. So first, you have to count the cases or health events and describe them in terms of time, place, and person. Then we divide the number of cases by an appropriate denominator to calculate rates, and then we compare these rates over time or for different groups of people in order to make informed scientific decisions involving diseases or health conditions, et cetera, et cetera. But first, before we talk about comparing the rates of cases, we have to talk about defining a case. So what do we mean by step one, count the cases? So it means we have to decide who has this disease and does this person actually have this disease or something else? So by defining a case, we introduce very specific parameters that say this is the case in order to ensure comparability and make sure every case is equivalent regardless of when or where it occurred. Because there's always the issue that, oh, maybe from this place to this place, they're defining it a little bit differently. So is it really the same case? So instead, we have something called a case definition, which everybody uses in order to say this is the disease. So a case definition is a set of standard criteria for classifying whether a person has a particular disease, syndrome, or other health condition. This is controlled by the Council of State and Territorial Epidemiologists, the CSTE, the CDC, and other adopted standard case definitions for notifiable infectious diseases. Now, these organizations work on an international level to ensure comparability around the world, but sometimes some case definitions are tailored to the local situation. Here's an example to help clarify this term. So if we're talking about a local outbreak investigation, sometimes the case definition might be kind of altered because the case definition might require a laboratory confirmation where such laboratory services are available, but likely would not if such services were not really available. Because in that case, if we had to have laboratory confirmation in the case definition, then we would severely underestimate the number of cases, and that would just be incorrect data in order to base decisions on. So sometimes we have to think more about what is happening in that particular place, particular time, et cetera, et cetera. So moving on to the components of a case definition. So a case definition consists of clinical criteria and sometimes limitations on time, place, and person. So by clinical criteria, we're talking about confirmatory laboratory tests, if they're available, a combination of symptoms, which are subjective complaints that you might give to a doctor, some signs like objective physical findings, or something else if applicable. And for limitations on time, place, and person, so outbreak investigations are more likely to specify limits than those used for surveillance, mostly because when we're talking about outbreak, sometimes we're focused on a very small moment in time, small group of people. For example, if we have a disease that broke out in, let's say, June, that's when the first case was recorded, then we wouldn't count any case before that date. So if we had one in January of the same year that has relatively the same clinical criteria, maybe a cough, sore throat, we wouldn't count it as a case towards this outbreak investigation because it's not in the same time frame, even if the clinical criteria does match. But for surveillance, of course, we're trying to get the whole picture, so everything would be included so we wouldn't have these limitations. Now, let's take a look at the listeriosis surveillance case definition, and we're going to compare that with the outbreak case definition. So the clinical description of listeriosis is an infection caused by Listeria myocytogenes, which may produce any several clinical syndromes, including stillbirth, including listeriosis of the newborn, meningitis, bacteriemia, or localized infections. So these would be our clinical criteria. Now, for laboratory criteria, we need an isolation of the virus from a normal sterile site. For example, the blood or the cerebrospinal fluid, or less commonly, joint, pleural, or pericardial fluid. And then we go into the case classification confirmed, which is when a clinically compatible case that is laboratory confirmed is present. Now, if we take a look at the outbreak case definition, we see we have the same clinical description and the same laboratory criteria, except when we go to get a confirmed case, we're talking about a clinically compatible illness in a resident of Winston-Salem, North Carolina, with onset between October 24th, 2000 and January 4th, 2001. So now we don't have mention of the laboratory criteria. It just says clinically compatible illness, and it gives us limitations on the place and the limitation on the time. So let's talk more about the components of a case definition. So many case definitions, such as that shown for listeriosis, require laboratory confirmation, as I mentioned in the previous slide, but it's not always necessary. This is not going to be the only case definition that will not have lab confirmation, because with some diseases, there are no distinctive laboratory findings. So if we take Kawasaki syndrome, for example, Kawasaki syndrome is a childhood illness with fever and rash that has no known cause and no specifically distinctive laboratory findings. So if we take a look at that case definition, we see a bigger clinical description, and laboratory criteria just says none, because we don't have any way to test for it in a lab. So let me just go through the clinical description. So Kawasaki syndrome is a febrile illness of greater than or equal to 5 days duration, with at least 4 or 5 of the following physical findings and no other more reasonable explanation for the observed clinical findings. So this is one where we have the no other more reasonable explanation. So that means we ruled out every single other thing using, most likely, lab confirmation. So here are some of the physical findings that we might have. So bilateral conjunctival injection, oral changes, peripheral extremity changes, a rash, or a cervical lymphadenopathy. And then our confirmed case would be one that meets the clinical case definition and no mention of laboratory criteria. So let's go more into the criteria for case definitions. So for the criteria, there are 3: suspected cases, probable or possible cases, and confirmed cases. So this is listed in order of how likely it is that this person has that disease, that this case is a real case. So suspected being the least certain and confirmed being the most certain. So let's take a look at measles, for example. So in the measles case definition, we have the clinical description being an illness characterized by all of the following: a generalized rash lasting greater than or equal to 3 days, a temperature greater than or equal to 101 degrees Fahrenheit, cough, coryza, or conjunctivitis. Laboratory criteria is a positive serologic test for measles immunoglobulin M antibody, or a significant rise in measles antibody level by any standard serologic assay, or isolation of measles virus from a clinical specimen. So both of these are very in-depth for diagnosing this disease. For our case classification, of course, before I only showed the confirmed cases, now we have 3 more criteria. We have suspected, probable. Possible is not included in this one, but some case definitions do have possible, and confirmed. So suspected is any febrile illness accompanied by a rash. So as I mentioned before, very loosely related to the disease. It's only suspected, not very certain. Probable is a step up. It's a case that meets the clinical case definition, has non-contributory or no serologic virology testing, and is not epidemiologically linked to a confirmed case. So it is a step up, but is not quite confirmed because we have the clinical case definition, but so far we don't have any lab confirmation. Now, confirmed is one that has both lab confirmation and meets the clinical case definition, and is epidemiologically linked to a confirmed case. So because we know that measles is contagious, so that is something important that we have to add here. And just a little note, a laboratory confirmed case does not need to meet the clinical case definition completely. If we detect measles in the body, just because you don't have a certain symptom doesn't mean that you don't have the disease. So lab confirmation is very important. And here is a comment that is also in the case definition. So confirmed cases should be reported to the National Notifiable Disease Surveillance System. And here's where it talks about an imported case. So of course we know that diseases are not limited by the borders that we draw on maps, but of course we follow that because we're thinking about location. So if the case is international, it means that it was imported from another country. And if it's out of state, it means that it was imported from another state in the US. You can pause here to read the whole comment if you want to, but I'm just going to move on. So let's talk more about why a case might be classified as suspected or probable. Well, it's because a case can be reclassified later as confirmed or not a case, depending on the laboratory results. And we want to mark these cases as maybe, and we're taking a closer look. And also, sometimes they might be marked like this because they are waiting for a laboratory test to confirm it or deny it. Sometimes officials may feel that laboratory tests are unnecessary because they have a consistent clinical picture and a history of exposure. So they might not run one because they might feel it's wasteful and instead just mark it as probable. But yeah, something to consider. So now moving on, we're going to talk about modifying case definitions. So here is another example for a SARS virus. So on March 21st of 2003, the first case definition for SARS was based on clinical symptoms and either contact with the case or travel to an area with SARS transmission. As we can see, we're basing it on how the disease spreads and clinical case, or no mention of laboratory findings right now. And on March 29, 2003, after a novel coronavirus was determined to be the causative agent, an interim surveillance case definition was published that included laboratory criteria for evidence of infection with the SARS-associated coronavirus. Then, in December 2003, in anticipation of a new wave of cases in 2004, a revised and much more complex case definition was published. So this means that the case definition is constantly evolving. It's evolving because we get more information about the disease and what's causing it, or it might just be evolving because we're getting new technologies, new ways of detecting the disease, diagnosing it, curing it. So as we advance, so do our case definitions. So here is the preliminary case definition for SARS. This is as of March 21st, 2003. This is the first case definition that they came out with. So a suspected case will have a respiratory illness of unknown etiology with onset since February 1st, 2003, and the following criteria: a documented temperature of greater than 104 degrees Fahrenheit, one or more symptoms with respiratory illnesses, and close contact within 10 days of onset of symptoms with the person under investigation for or suspected of having SARS, or travel within 10 days of onset of symptoms to an area of documented transmission of SARS as defined by the World Health Organization. So now that I've given you that, let's do a little bit of practice. Explain how the case definition might address the purposes listed below. And remember that it is a preliminary case definition, so you do want to evaluate the effectiveness of how it accomplishes each of the purposes. So let's go through these together. So first, diagnosing and caring for individual patients. You can go back to the case definition in order to think about the question and answer it. But here is the answer. So the third criterion may be limiting because the patient may not be aware of close contact, but otherwise is effective. So if we go back to the case definition, our third criteria was close contact. And it's true, this is a relatively new outbreak. So people might not know that they have friends or family who have had it before because previously it was not diagnosed like that. But our other symptoms, high temperature, one or more symptoms, that would be very helpful for diagnosing and then later caring for people with the disease. So tracking the occurrence of disease. Probably reasonable. We are going to be tracking people that have 10 days with onset and people who have recently traveled to that area. So it would be pretty effective to figure out who has had contact and who is more at risk. Doing research to identify the cause of the disease. So the criteria do not require sophisticated evaluation or testing, so it can be used anywhere in the world. And finally, deciding who should be quarantined. So this preliminary case definition would be too broad because most people with a cough or fever returning from Toronto, China, etc., are more likely to have upper respiratory infection than SARS. And also we have to consider that the case definition only said one or more of the symptoms and a high temperature. And well, close contact may or may not be, but of course, we are going to overestimate the number of people with the disease with the preliminary case definition. Okay, so moving on to variations in case definitions, we have two types of case definitions, a sensitive case def and a specific case def. So a sensitive one is a case definition that is broad or loose in the hope of capturing most or all of the true cases. On the other hand, a specific case definition is one that is very strict to be certain of the occurrence of disease. Now, each of these have their advantages and disadvantages that we will weigh in the next slide. So the advantage of a sensitive case definition is that it includes most or all of the true cases, so we're more likely to get everyone who has the disease. The disadvantage is that it sometimes includes other illnesses as well that may be similar, and the total number of cases will be overestimated. Now, you might think, oh, that's terrible. We don't want people thinking they have this disease when they really don't. But sometimes it's necessary if you are dealing with an outbreak. Because when you're dealing with an outbreak, you want to make sure you are controlling the disease. It's best if everyone that has a disease so you can stop it from spreading. It's okay if there's a couple of people in there who don't have the disease because you are going to have almost all of the true cases. Now, a specific case definition, on the other hand, the advantage is that investigators would be more likely to identify the source of the infection because they're only going to include people who are confirmed to have been infected. The disadvantage is that everybody with symptoms needs to be tested and the total number of cases should be underestimated. Now, a specific case definition is also important because we want to make sure that these people really have the disease. So if we were dealing with a bout of food poisoning, we want to know what caused it. We would find out what caused it by testing the people that we know are confirmed to have food poisoning rather than just an upset stomach. So let's practice with the trichinosis case definition. I want you to read all of this, the criteria for confirmed, probable, possible, suspect, and not. And on the next slide, I'm going to give you a list of things, and you're going to tell me whether the case is confirmed, probable, possible, suspect, or not. So take a moment to read through these. And now let me show you the information. So for our first person, we have yes for myalgias, fever, no for facial edema, and eosinophil count is 495. The physician diagnosed it as trichinosis, and the lab confirmation says yes. What would be the classification? Confirmed, because we have lab confirmation, and even though we don't have 3 of the 4 being abnormal, which is required for the probable one, at least 3 of the 4, we have the signs and symptoms, and we have laboratory confirmation, so that would be confirmed. For the second one, take a moment to read through it. The classification would be probable, because the lab confirmation is pending, so we don't have a clear yes on that, so it can't be confirmed. But we can take a look at the symptoms. Already, even though we have the eosinophil count as pending, we already have 3 of the 4 symptoms present, so probable. Now read the next one. So the case classification would be probable as well. Once again, no laboratory confirmation, and we have 3 of the 4 symptoms present. Okay, now ID number 4. The case classification would be probable too. No lab confirmation and 3 of the 4 symptoms. Now the last one. And the last one would be possible. We don't have lab confirmation and we only have 2 of the 4 symptoms present, but we do have a physician diagnosis of trichinosis, which would put it as possible. If we didn't have the diagnosis as that, we would not be able to say possible. The other ones, the confirmed, probable, they don't need the physician diagnosis because you have the symptoms or because you have the lab confirmation. But when you don't have all the symptoms, if the physician is sure of the diagnosis, then you can say it's possible. All right, and that brings us to the end of our lesson. I hope you learned a lot today. And remember to subscribe to One Word Anchor so we can continue making these videos for you guys. And please like the video if you want to learn more about epidemiology. Until next time, bye!